Awesome. Great. Thank you everybody so much for being here. This is the second Opioid Learning Institute Community of Practice on the dosing model. And we have Dr. Michael Serlin here with us. And this community of practice is run through the Opioid Learning Institute, which is a program under Health HIV. To give a little information about Health HIV, we're an organization that advances effective prevention, care, support, and health equity for people living with or at risk for HIV and hepatitis C, particularly with the LGBTQ and other underserved communities, by providing education, capacity building, health services research, and advocacy to organizations, communities, and professionals. This is the second Opioid Learning Institute community practice, as I mentioned, and the Opioid Learning Institute is a comprehensive educational initiative with a mission to educate prescribers and other healthcare professionals on safe and effective opioid prescribing practices. The self-paced CME CE accredited curriculum covers topics related to evidence-based opioid treatment options, safe opioid prescribing, reduction of risks of opioid use or misuse, effective communication strategies with patients about opioid misuse, and overdose prevention. And this community of practice is meant to be interactive. But since it's accredited, we will have an educational component that Dr. Michael Serlin will present, and then we'll open it up for discussion where everyone can filter into the room. And then I totally forgot to introduce myself, but my name is Henry Budenshane, and I'm a senior capacity building coordinator with Health HIV. And we also have Ken Pettigrew. So Ken, if you'd like to introduce yourself as well.
Sure. Thank you, Henry. Again, my name is Ken Pettigrew. I am the new director for capacity building here at Health HIV, which also includes the Opioid Learning Institute, and happy to be a part of this and look forward to a great webinar and discussion.
Awesome.
Henry?
Thank you, Ken. Yeah, it's great to have Ken on board. So we're super excited. So now I'll introduce Dr. Serlin. So Dr. Serlin is the medical director of Family and Medical Counseling Service. He has over 19 years of experience providing care to HIV and hepatitis patients and those who are at risk for that. He's worked as a medical director for HIV programs in DC, Virginia, and New York City since 2007. He is the clinical associate professor of medicine at George Washington University School of Medical and Health Sciences and is board certified in internal medicine and infectious diseases. Dr. Serlin has been a site principal investigator or co-investigator on several research studies, including ongoing studies at FMCS. So thank you so much, Dr. Serlin, for taking the time to be here. And now I'll turn it over to you.
Yeah, thank you very much for inviting me and having me. As you guys mentioned, I am the medical director at FMCS. I've been there for about 5 years. And FMCS, I think, is an excellent place to discuss these things because originally the medical clinic was established as an HIV clinic before broadening to include primary care and pediatrics. We have 2 sites, our main site in Anacostia in Southeast DC, as well as a newer site for the last few years in Seat Pleasant, Maryland. And we, in addition to the medical services we offer, we also have behavioral health services, substance abuse services. We have a needle exchange program, both in DC and in Prince George's County, in addition to case management and care coordination. And so there's a lot of stuff that we do at FMCS that's related to the topic that we're discussing today in relationship to opioid use disorder, as well as hepatitis, which we'll get into in a little bit. Let me go share my screen for the presentation. Give me a second. Just seem to have lost it from sharing. There we go. Okay. So I do want to, since it's sort of a case study, then I do hope that it is somewhat interactive. I realize in a Zoom setting, obviously it's a little bit more different. People aren't going to be able to chime in verbally, but I will be trying to monitor, or Henry will be trying to monitor as well, the Q&A box. And so if there are questions that are pertinent to what I'm discussing at that time, I'm happy to stop in the middle and answer them accordingly. So basically the way I set this up is just to go over a case study of a patient that presented at FMCS, or a type of patient that presents at FMCS. So I'll get into that now. So we have a 51-year-old African-American male who presents to enroll in a substance abuse program at FMCS. He comes over to the medical clinic. He's referred over there because as an opioid user, he was interested in also considering starting buprenorphine therapy. So he doesn't take any meds. He's not allergic to any medications. He has a history of depression, but no other medical issues. He has no complaints other than elbow pain. And his exam is normal with normal vital signs, and his pupils are normal, so they're not either constricted or dilated. So as far as the next steps of what to do, as far as evaluating him for potential medication-assisted treatment of opioid use disorder, if you want to enroll him into an MAT program, so MAT is short for medication-assisted therapy, which we generally consider buprenorphine treatment. So you want to assess the patient's motivation. You want to know why they're interested in starting medication-assisted therapy. Like, is it because they've been using too much? A lot of times I get from patients that they've lost some friends or family members due to overdoses. Obviously, there's a lot of fentanyl going around. There's been carfentanil going around. These things are a lot more potent, and people, unfortunately, take them and aren't able to wake up from them. And so there's a lot of opioid deaths in DC as well as nationwide. So that could be part of the patient's motivation. You want to know, when did the patient last use drugs, and what drugs are they using? How often? How are they being used? So, we certainly get a lot of patients who are using heroin off the street. Some people snort it, some people skin pop, some people inject. And you want to know, how much are they using in a day? Are they using 1 dime bag? Are they using 1 gram, 2 grams? Are they using it several times a day? Are they only using it once a day? Are they using it to get high, or are they using it to prevent them from withdrawal? We also have a lot of patients that come in that have never used heroin, but instead that they're using pills. Some of them are using pills because they had some sort of injury and they haven't been able to kick using narcotics, whether that's oxycodone or Dilaudid or Percocet. Certainly, there's a lot of people who come in just using pills. Sometimes those patients start with pills and then go into heroin when they're cut off from getting those pills. But other times it's just, they're on pills and they want to try to kick that. And again, how are they being used? How are they, are they ingesting it or skin popping or snorting? You want to assess signs of withdrawal. The main way we do that is called the COWS score, which I'll get into in a little bit. And on the physical exam, you want to assess, certainly you want to check their pupils. Are they constricted? Are they dilated? You want to assess if they have any IV track marks, if they're an IV drug user. Have they been using IV drugs in the past? A lot of times patients will have scarring on their arms or even their legs because of that. You want to know if they have any abscesses or cellulitis, if they are currently using. Obviously, patients who are injecting are at risk for getting infections related to that, and sometimes those could be pretty serious. So the COWS is a clinical opioid withdrawal scale. I'm sorry, it's not the largest font, but basically what you're doing is there's about 10 different parameters here, and you want to assess, 1, whether or not the patients are reporting some of these complaints, and 2, whether or not you're gleaning anything from their physical exam. So the resting pulse rate, the higher the pulse rate is more indicative of maybe being in more withdrawal, and so that has a higher score. You want to know if they've been sweating a lot, if they've been flushing, or they're having sweating or chills. You want to know about their restlessness, whether or not they're reporting it, or you're observing that they're really unable to sit still because of their withdrawal. You want to look at their pupil size, whether it's normal or if they're dilated again being more a sign of withdrawal. You want to know if they're reporting any bone or joint aches, if they have a runny nose or if they have tearing. Again, those are also signs of withdrawal. If they've had any stomach upset, nausea, vomiting, diarrhea. If they have a tremor, if you notice them, a lot of times I'll ask patients to raise their hands in front of them and see whether or not they could be steady or if they're jittery for that. You want to know if they're yawning or if you see them yawning. Again, yawning is indicative of withdrawal. If they're anxious or irritable. And lastly, you want to know whether or not they have any goose flesh or goose pimples. And so if you do see that, then that also could be a sign of withdrawal. And so you add up all these scores. And if it's a low score, then it's mild withdrawal. Whereas if it's a higher score, then it could be moderate to severe or even severe withdrawal. So some of the tests we do for the patient who is interested in MAT therapy. One thing we do is we do an EKG on everyone upon their initiation of buprenorphine treatment. The reason for this is that if they have a prolonged QT interval, that could predispose them for an arrhythmia if they are put on either buprenorphine or actually methadone as well. So that's one thing to sort of watch out for, because if you have a patient who has a prolonged QT interval even before they start buprenorphine, that's something you should weigh as far as the pros or cons are concerned. Labs that we typically check include a CBC, complete metabolic panel, especially looking for signs of liver dysfunction, as well as kidney dysfunction. You want to know their hepatitis serology, which I'll be delving into a bit more going forward. You want to know about if they've had to test their HIV, because certainly patients who are using drugs may also be utilizing risky behaviors. There certainly are people who, obviously IV drugs, if you share a needle, that is a major risk factor for HIV with someone who's HIV positive. But even if you're not sharing needles, there are certainly patients who, there are certainly people, who may trade drugs for sex, for example, and those are engaging in risky behaviors and things like that. Certainly you want to do a drug test because you want to know about if the patient is utilizing other substances in addition to opioids, as well as sort of confirm whether or not they're taking opioids, as well as what opioids are they taking, and maybe they're already been exposed to buprenorphine, maybe they're already getting methadone. So that's good information for you to have at the outset. And one thing we do as a primary care clinic at FMCS, we also, if a patient is not in primary care elsewhere, as long as we're drawing these labs, we may offer to do their annual labs as well. So things that aren't necessarily indicative or indicated in just starting a patient on medication-assisted therapy, but we may also do STD screening. We may also do hemoglobin A1C. And certainly if a patient wants to establish primary care with us, if they're old enough, we might even consider talking to them about colon cancer screening or breast cancer screening with a mammogram. Though obviously, I think the important thing to realize is that because they're here to initiate MAT treatment, you don't necessarily want to get bogged down in a lot of other things. So sometimes I'll order those labs as long as I'm drawing blood work, but I may not necessarily be addressing primary care until they follow up and they're more comfortable on the MAT treatment that they're taking. And you should not delay treatment initiation while awaiting lab results. So it's good to have this baseline information available, but as long as the patient is in the room, I often will start them on buprenorphine therapy unless there's a specific reason not to. I would often start them on buprenorphine therapy and then have them do a close follow-up, generally within a week, to see how they're doing once we start them. We'll get into that in a little bit. But the important thing is don't tell them they're here now and they're presenting, sort of saying, I'm ready to start buprenorphine treatment. And so the important thing is to ensure that that you don't lose them. You don't say, okay, well, I'll check blood work and come back in 2 days, because they very well might not come back in 2 days. And the longer that it takes for you to put them on that buprenorphine therapy, the more at risk they are for starting to use drugs again or continuing to use drugs and perhaps overdosing. So that's a very important thing. Another thing you want to do is to assess the PDMP, so the prescription drug monitoring program. We do have that obviously in DC as well as Maryland and Virginia through CRISP, the Chesapeake region informational exchange. I forgot exactly what CRISP stands for, but through CRISP, you could actually access the controlled substances that are being prescribed throughout the region. And in the EMR that I use, which is eClinicalWorks, whenever a patient comes in, if you're prescribing something, it automatically clicks to a link to the PDMP. So if I'm refilling or starting a patient on buprenorphine or really any other medication, it'll click to the PDMP so I could see what they're being prescribed. So it's good to know, one, is the patient currently in care elsewhere? Are you seeing prescriptions from other providers? And you could ask them about that. You could see, patient maybe jumping to emergency room and getting 5 to 10 doses of oxycodone here or there. Or you could see, they're not currently getting buprenorphine therapy, but they were last November at another provider. And so that's just sort of good information to have. But then if the patient didn't volunteer that initially, you could ask them about their previous buprenorphine treatment. You also want to know whether or not they're receiving benzodiazepines. Benzodiazepines specifically, as well as alcohol and obviously other opioids, they can interact with the buprenorphine that you're giving to exacerbate respiratory depression. And so certainly if you're taking benzos, or you're drinking alcohol, you're using buprenorphine or other opioids, those are all respiratory suppressants, and those combinations together can often lead to overdosing and things like that. And again, you could assess whether or not they've received buprenorphine before. And then you also want them, ideally, is to sign, you want them to set up rules for signing an MAT contract. And so it's important that, really probably with any controlled substances, but certainly with buprenorphine therapy, you want to set some ground rules for the patient as far as, when they're going to be coming into the clinic, because you want them to adhere to certain guidelines. You want to make sure that they're agreeing that they're not going to be, we'll go over a sample MAT contract in a minute, but basically you want to agree that they're not going to sell their medications. They're not going to, cause a ruckus in the waiting room. They're not going to be causing a lot of problems because, this is, in addition to being medication-assisted therapy, you also want to make sure they're adhering to certain behaviors that could keep them in, on the right path, and you don't want them to be really abusing that. I do see a question in the Q&A. Sean Hicks, hi Sean, asked, what are the reasons for not starting MAT treatment? In generally, when patients do present, we do start them on MAT treatment. I think one reason may be that, for example, I had a recent patient who presented because they were interested in starting MAT treatment, but actually they had been clean for 2 or 3 months. And they had been using pills before, they were clean for 2 or 3 months. And so I talked with that patient and said, listen, you've already been clean for 2 or 3 months. Are you sure you want to start this therapy? Because you've proven that you've been able to remain clean without that. And so we both agreed that we would give it another week or two to see, so he could sort of do a self-assessment about his urges about whether or not he really wants to start or if he thinks he's good on his own. And so that patient did follow back up in 2 weeks and said, listen, I haven't used drugs, but I still feel these urges and I want to start. And so I was able to start him on a low dose, but that could be a potential reason that maybe you wouldn't necessarily start it on day one, as an example. But there could be other reasons too. If the patient received buprenorphine therapy from another provider last week, then I'm probably not going to be prescribing to him today. Could I be kidding? Well, you just got 30 or 60 films of Suboxone from this other doctor last week. I'm not going to give you another prescription today because maybe that patient would use that prescription and take it to another pharmacy and things like that. And that's why the PDMP is very important to assess. So continuing on. So this is a sample MAT agreement. This is similar to the one we use at FMCS, but not exactly the same. But this is from the OBAT clinical guidelines. And you can look this up on the web. And so basically just going over, and I'm not going to read everything specifically, but basically going over just parameters for what we're agreeing to by having this, that we're prescribing the MAT and what the patient's agreeing to. So they freely and voluntarily agree to the treatment agreement. They agree to do their best to keep their scheduled appointments. Certainly, at least at FMCS, we have some leeway. If a patient misses an appointment, we'll work with them and let them walk in a day or two later, because we don't want them to go without their buprenorphine therapy. But you don't really want a patient really just abusing them and showing up at all hours whenever they want. They'll report any substance abuse and discuss high-risk behaviors with the treatment team. That's to help decrease the risk of overdose or infection and protect their safety. You agree that to also enter various other forms of treatment. So, medication-assisted therapy is really just sort of one way that we could help the patient kick their opioid habit, but it's not the only way. We are fortunate at FMCS to have a few different programs. We have a substance abuse program. We have a program of case managers and care coordinators on our early intervention services program that really work hand in hand with these patients to try to help them be as safe as possible, and work with them to try to reduce their opportunities to use drugs and do a lot of real harm reduction for that. Again, we also have a needle exchange program. So we're giving out needles in the field, both in DC and in Prince George's County, so that those patients are less at risk for getting infections, especially HIV and hepatitis C from that. I will attend my appointments prior to running out of prescriptions and keep my medication in a safe and secure place. Oftentimes, if we, diversion is an issue. Certainly, not all of our patients divert, and most of our patients actually do quite well on buprenorphine therapy, but there certainly are patients who will get the prescriptions and sell the Suboxone strips or buprenorphine strips and use the money to buy other drugs. And so it's important that you really take a good care of that. The patients who will say, my Suboxone was stolen, can I get a new prescription? You really want them to avoid that, and oftentimes we'll have them fill out police reports and things like that to help document that. And often we're not going to let patients do that every month, because that again is a increased sign of being diversion. I will inform my patient the medication I'm receiving no longer works, so we can make a new treatment plan. I agree not to sell, share, or give away any of my medications. I will not engage in behavior or jeopardize anyone in the clinic. I will not falsify or tamper with my drug tests. We do the drug tests that we use also show the buprenorphine to norbuprenorphine ratio. And they also show the patient's urinary creatinine. So you could tell if a patient is just giving water and submitting his urine. You could tell if a patient is dipping their Suboxone stick in water and passing it off as urine. So those are things that we try to observe. I agree to random callback visits, include toxicology screens and medication counts. I agree to obtain my medication. Not that if I obtain medication from other prescribers or pharmacies, I will inform the team. I also understand it mixes with other substances, especially benzodiazepines like alcohol, and it could cause death. So basically, those are all things that we have. And again, our MAT agreement is not this exact thing. I have a PDF, so I couldn't really share it, but it is similar to what we discussed over here. Again, according to SAMHSA, it's very important to have care coordination agreements and care transitions. You want to make sure that you are coordinating responsibility of participating providers, facilities, and services to agree to ensure that those responsibilities are orderly and promote the highest quality of care as possible. So again, we are fortunate at FMCS that a lot of those care agreements are sort of internal, but again, we also work with a lot of outside services, and there are other certainly forms of treatment for opioid use disorder, including inpatient treatment, whether that's a short detox or much longer, 28 days, or we certainly have patients who go to places in West Virginia for 3 or 4 months. These are all different things that we utilize as part of our armamentarium of treating opioid use disorder. Continuing on. So initiation. So you want to educate the patient about how the medication works and the associated risks and benefits. You want to obtain informed consent and educate on overdose prevention. Other things we do, especially with our care coordinators, is we could give fentanyl test strips so that they can test their drugs to know if there's presence of fentanyl. We also give out Narcan as well, naloxone, so that patients have it on them. So if they or their friends or colleagues are overdosing, that they could utilize that and spray in the nose to help prevent them from dying, obviously. And you want to evaluate the need for medically managed opioid withdrawal from opioids, because those, when you initiate the buprenorphine, they need to be in a state of withdrawal, because if you start it when they've just used heroin or taken pills, then the naloxone component of Suboxone, so it's buprenorphine and naloxone, the naloxone component will reverse that. So you want to make sure they're in some form of withdrawal before starting. And again, you also want to address co-occurring disorders. So certainly, if they have mental health issues, you want to try to enroll them in mental health therapy so that those could be treated at the same time, whether that's through pharmacological therapies or non-pharmacological therapies. And you refer patients for a higher level of care if necessary. In addition, obviously, support groups are extremely important, whether that's NA or AA or things like that. Those are also very important for the patients to help maintain their sobriety. So when you're considering inducting the patient, you want to use, if they have long-acting opioids such as methadone, then it might be 48 to 72 hours for them to actually have a mild state of withdrawal before initiating the buprenorphine. If they're short-acting opioids like heroin, basically it's at least 12 hours. Fentanyl might need more than 12 hours. And again, the clinical presentation, by utilizing the COW score, that should guide that decision, as the individual presentations may vary. So if patients tell me when they present to me initially that they used this morning, a lot of times I might say, well, maybe I'll prescribe medication to say you should start it tomorrow, or maybe I'll say come back tomorrow and we can start it then. But I'm more likely to just prescribe it and then tell them to start it tomorrow when they are in a mild state of withdrawal. So our patient, so his EKG was normal. Again, we sent his labs, but we didn't have the results yet. He signed his contract. His COW score was relatively low. It was 4. And so he was in mild withdrawal. And so I started him on buprenorphine naloxone 4-1. So it's 4 milligrams of buprenorphine and 1 milligram of naloxone. I prescribed it daily for a week, but I gave him 10 days worth because I want to, and I'm going to have him follow up in like 5 to 7 days. So I'm giving him a few extra strips in case he needs it. So if he starts with 1 strip, but he actually needs 2, if he feels the urge, that evening, then I want to make sure he has that extra buprenorphine so that he doesn't run out and then, maybe use drugs before I see him again. So that's why I try to give him a little bit more medication than he's going to need, and then have him follow up before that medication is going to run out, so that we could assess. And then maybe the next visit, maybe he needs it twice a day, and I'll prescribe that and then give him a little bit more, or maybe I'll increase him to 8 milligrams at that point in time. Again, you want to consider whether office or home induction. When we started doing buprenorphine, or at least I started doing buprenorphine at FMCS 5 years ago, we almost exclusively in-office induction. So we would give the patient the prescription, they would go to the pharmacy, or we would send it electronically. They would go to the pharmacy, they would get it filled, they would come back, and then we would monitor them for their first visit. I think especially compared with, say, 2017 or 2018, there's a lot more patients that have already been exposed to buprenorphine by the time I see them, even if they're presenting for initial. They've used it off the street, they've gotten strips from their friends, they used it a few years ago, they used it in prison or when they were incarcerated. And so a lot more patients have had exposure. And so if I'm initiating it or reinitiating it, I'm confident that they know how to take it. But if they don't, I could always then again have them go to the pharmacy, come back to the clinic, and then we could watch them take their first dose and then monitor them for 15 minutes to a half hour just to make sure that they're not going to get somnolent or fall out. But again, starting on a low dose, especially to patients who have been exposed to opioids, that generally hasn't happened. And I think a lot of places are sort of comfortable doing home induction now. And certainly I think that's what we've been doing at FMCS for a majority of patients in the last 2-3 years. One important thing is that one of the major changes in DC is that going back 3-4 years ago, whenever you prescribe the buprenorphine therapy, you need to get a prior authorization. So I would need to call DC Medicaid and talk to them for 15-20 minutes whenever I started a patient on buprenorphine so that they could be approved for it. And that obviously was a major barrier to prescribing buprenorphine. In addition to that, needing to do the trainings to get the XDEA waiver, those were barriers. And especially with the prior authorization requirement being removed, that has allowed us to prescribe a lot more buprenorphine to the patients who really need it. So his labs came back. Again, I was going to have him come back in 5 to 7 days. I think it was for a week for him. So his CBC and his CMP was normal. His HIV test was negative. His drug test showed that he had both, he was positive for cocaine and opioids, including fentanyl and morphine. His Hep C test was positive, and he was not immune to hepatitis A and hepatitis B. So as far as the next part of our talk, is going to be more so about, what do we do about this Hep C positive test? So we're going to be treating his OUD with medication-assisted therapy. We're going to be providing him buprenorphine. He's going to come back in a week. Maybe we're tapering or increasing the medication based on his dependence level. But at some point, we're sort of going to get a steady state where he's going to be taking, 8/2, once a day or twice a day, and he's going to be comfortable with that. We're going to be doing periodic drug tests. Right? Hopefully, he's going to be already enrolled with substance abuse therapy and mental health therapy because he's depressed. So we're going to be working on that. But in addition to that, we could also try to treat and cure his hepatitis C. And so that's what we're going to discuss now for the rest of the talk. Just before continuing on, I just want to give a brief, are there any other questions right now before sort of segueing into more talk about hepatitis C therapy and treatment? And obviously I'll be monitoring the Q&A. So if anything pops up, we could certainly take a look at that. So again, the next step, so again, we'll manage his opioid use disorder with the MAT. I'm not going to go into that further, but I did want to discuss sort of like an initial patient presentation, as well as discussion about the initial induction of buprenorphine. So since he's not immune to hepatitis A and hepatitis B, and our particular patient was an IV drug user, we certainly, or actually he was using drugs, we certainly want to, in addition to treating his hepatitis C, we want to protect him against getting either hepatitis A or hepatitis B. And so the ways to do that are through shots. So most kids are immunized against that now. So certainly I think probably pretty much anyone under 25 even have been given these shots as they were growing up as part of their regular pediatric vaccines. But you also, if they are not immune, and our patient is in his 50s, you could give him vaccination for both hepatitis A and hepatitis B. And actually there are combined hepatitis A and B vaccines. So you give a combined Hep A, B shot today, they come back next month, especially because they're getting MAT treatment. You give it a Hep B shot because there's 3 shots over 6 months. And then, 5 more months down the line, you could give that combined shot again. In addition, obviously, as long as we're discussing this, I would also, if the patient hasn't had COVID vaccine yet, I would certainly encourage him to get that done. And then you want to talk about hepatitis C treatment. So hepatitis C overview. So we're just basically going to go over current Hep C demographics, talking about testing and linkage, the current hepatitis C therapies, the main ones that we use right now, and some resources as well as drug interactions. So the risks of getting hepatitis C, so it's blood transfusions before 1992. That was before they developed an excellent screening of the blood supply for hepatitis. Healthcare workers who have needle sticks, that's a risk. IV drug users, obviously. Infants born to Hep C positive mothers, people engaging in high-risk sexual behaviors, whether that's commercial sex work or men who have sex with other men, or patients with multiple partners, especially if they're not using condoms. Sorting cocaine or heroin using shared equipment. So this is something that's surprising to a lot of patients that I tell them they have hepatitis C. They're like, I'm not an IV drug user. I've never had a needle or anything like that. But sharing a straw, so if you're snorting cocaine or you're snorting heroin and you're using a straw and you share it with a colleague, that is one way you could pass hepatitis C, because there is a little bit of blood that could happen when you're snorting drugs, and then passing that along, you're sort of introducing that blood to someone else's nose, and that could cause hepatitis C. And also shared razors, toothbrushes, and personal items, including tattoos. So a lot of times that may happen, for example, if someone's incarcerated or things like that, or someone goes to a barber or a tattoo parlor and they're not properly cleaning their sterilizing their instruments. So this is the incidence of hepatitis C, so the newly diagnosed hepatitis C cases in the United States over the last 40 years. And again, there was a lot more hepatitis C diagnosed in the mid to late 80s and early 90s before we're effectively screening the blood supply. There were a lot of patients, for example, with hemophilia who always were receiving blood products, including Ryan White, who were getting HIV and hepatitis C through those occurrences. And so for the Hep C prevalence, so patients who have new Hep C infections, some of them, about maybe 10%, 5 to 10%, may spontaneously clear. So they get hepatitis C, but they sort of cure it on their own. So they get hepatitis C, they have a viral load, and it just sort of goes up and down, and it clears on their own. A vast majority of patients just sort of live with hepatitis C. Some of those patients die. A lot of times that could be from getting cirrhosis, and cirrhosis then could lead to either liver failure or hepatocellular carcinoma or liver cancer. And then again, a lot of them get treated and cured. As we'll get into, our treatment rates are well over 95% for a relatively short period of treatment. But some of those patients do get reinfected. Again, if you're engaging in risky behaviors, it's certainly possible you could get reintroduced to hepatitis C. And I have had some patients that we've cured and have gotten hepatitis C again because they started re-engaging in risky behaviors. These are the mortality rates in the United States from 1999 to 2007. So you see, as HIV treatment got better with heart or antiretroviral therapy, that caused the death rate to go down from HIV. But Hep C death rates going up because especially a lot of these patients were from who were born between 1945, 1965, were getting Hep C, and this was maybe 20, 30 years after they contracted hepatitis C. And a lot of those patients were then developing liver cirrhosis and liver failure from that. The global health importance of hepatitis, I think it's from the WHO, showing that the mortality, the deaths from HIV, again, sort of peaked in the early 2000s. That's because the HIV treatments weren't rolled out worldwide until maybe 10 years they were after here in the United States. But those numbers have been going down. But chronic Hep B and Hep C here in blue, that has been consistently going up. And you see malaria has been sort of trending down with a lot of malaria efforts they've been doing in Africa, and also TB has been going down with some of the better treatments that we've been having. These are the annual deaths associated with Hep C here in the United States from the CDC, showing again, it peaked in 2014, 2015, but as we have much better therapy, really starting with Harvoni, which was introduced around 2014, 2015, really since then, since the therapies are so much more improved, the death rate has been going down over the last several years. Targets to eliminate Hep C, so more patients being diagnosed with Hep C, more patients on treatment for Hep C, more donations being screened. Again, this is from WHO, so this is worldwide. More harm reduction being given, and more safe injections, people using clean needles. In the global cascade of Hep C care, so the number of infected patients, again, there were few patients who were diagnosed, but the target is to diagnose a lot more, less patients being treated and less patients being cured. Again, this is from 2017, but as time goes on, we are treating a lot more patients. And again, the elimination cascade shows that to eliminate, basically, you have to do microelimination, maybe first all HIV positive patients, and then try to get all the patients in the country, all the patients in the clinic, and then the patient in and of himself. So a lot of these are from, I'll show the sources at the end, but a lot of this is from Hep C guidelines, HCVguidelines.org, which I think is an excellent resource. So the recommendations for one-time Hep C testing is recommended one time for all individuals 18 or older. It should be done for all patients 18 or older with activities, exposures, and conditions related to increased risk for Hep C infection. So whenever a new patient comes into our clinic, we're doing testing, we're assessing for Hep C, as well as Hep A and B serology, because again, we want to offer them immunization if they're not immune to that, regardless of what their risk factors may be, one time only. Prenatal Hep C testing for routine prenatal care is recommended for each pregnancy. Periodic repeat Hep C testing is for all people with exposure conditions, which we'll get into in a second. And then annual Hep C testing is recommended for everyone who injects drugs, HIV-infected men who have unprotected sex with other men, and other men who have sex with other men who are taking PrEP or pre-exposure prophylaxis. So these are the risk activities. So IV drug use, intranasal illicit drug use. So again, sharing straws, especially use of glass crack pipes. That could also, if you're sharing that with other people, that could be a risk. Men who have sex with other men, and engagement in chemsex. So using things like crystal meth or whatnot during sex. Risk exposures, including patients on long-term hemodialysis, people with exposures in unregulated setting, healthcare or emergency workers with needle stick or sharps or mucosal exposure. So it's not just people who stick themselves with a needle, but it could be, you know, a garbage man who accidentally gets stuck with a needle and they don't know where it's from. It could be a dentist who gets a splash in the eye and they're not sure about whether or not the source is Hep C positive, or if they are, or if they know that they're Hep C positive. Children born Hep C positive women, again, prior organ transfusions or prior transfusion or organ transplant, especially those before 92, and people who were ever incarcerated. And then again, HIV infection, as well as people who are on PrEP. And then for follow-up, if you do have, you could consider the antibody testing with a reflex RNA PCR. So if you do a Hep C test and it turns positive, a lot of tests you do can reflex to find out if you have a positive viral load. Because if you have a positive antibody, but your viral load is negative, then actually you don't need treatment. If you have a negative antibody test, but they are exposed to Hep C, then you could do it again. People at risk for reinfection. Quantitative Hep C RNA testing is recommended prior initiation of antiviral therapy to document the presence of baseline viremia. So you want to know what the viral load is. You want to also know the Hep C genotype. So that oftentimes is a test that we order, is that we check the viral load, but if it's a positive viral load, not only will it give you the number, but it'll actually give you what the genotype it is, whether it's 1A, 1B, 2, 3, or 4. Though with the treatments we use nowadays, because the treatments are, for the most part, pan-genotypic, it's less important to know what the genotype is. And also, so here, this is the general algorithm from the American Association, Society of Liver Disease, as well as the ID Society of America. You have a positive, if you have a negative Hep C antibody, then you don't need to do anything, but if you have a positive one, you check for the RNA. If it's not detected, then there's no current infection. You could try doing additional testing as appropriate, but if you do detect it, then you want to link them to care. And a lot of times patients get referred to us at FMCS if they have positive tests in the community. Then we have a positive test. You could do a rapid Hep C test. We do our own outreach and testing teams at FMCS, where we go to the Social Security office or the DMV or the Income Maintenance Center. We offer people Hep C and HIV testing. If they test positive, then we link them to care in our clinics so those can be treated. So if a patient tests positive for Hep C, then check for the viral load, the genotype. You want to do liver staging, so you could do that with either a Fibrosure, which is a blood test, a FibroScan, which is testing for elasticity in the liver. It's more sort of like an ultrasound, or you could do a biopsy. So before the Fibrosure or FibroScan, everyone who tested positive for Hep C got a liver biopsy to determine their stage of cirrhosis. And if you do have cirrhosis, you want to do some imaging every 6 to 12 months, like maybe a sonogram, sometimes CAT scan or MRI. And also you could consider getting alpha fetoprotein, which is what we do as well, because an elevated alpha fetoprotein is also indicative of possible hepatocellular carcinoma. So recommendations include abstaining from alcohol, evaluating for hepatitis B and or HIV if they weren't already tested. Again, you want to check their CBC, CNP, then PT-INR prior to treatment. The reason you want to check their coagulation profile is to see about if they have any liver issues causing coagulation problems. Again, you want to evaluate for advanced fibrosis. You want to vaccinate for Hep A or B, and then you want to educate about reducing the risk of Hep C transmission. So what the Fibrosure test is the blood test that you basically can do that looks at like 7 or 8 blood tests, or actually parameters, so gender and age, and then 6 blood tests, and puts them all into an algorithm that spits out whether or not the patient has F0, which is no fibrosis or scarring. It could be F1, 2, 3, or 4. Then 4 is cirrhosis. But you don't want to use that if they're have kidney issues or some other issues like Gilbert's disease, because with the elevated bilirubin, that could interfere with the calculations. So the Hep C treatment, so basically if they're naive, if they haven't been treated before and they don't have cirrhosis, or even if they do have compensated cirrhosis, basically there's 2 different regimens. One is Glecaprevir-pibrentasvir, which is also known as Mavyret. You take that 3 tablets daily for 8 weeks, or you can offer them Sofosbuvir-Velpatasvir, otherwise known as Epclusa, which is 1 tablet daily for 12 weeks. So Epclusa, that works for genotypes 1 through 6. It comes in generic form. And again, basically it's just 12 weeks of therapy for patients with cirrhosis, without cirrhosis or compensated cirrhosis. And this study, the original study back in 2015 about using this for pan-genotype shows that basically the success rates here for all these patients after 12 weeks was 97, 98, 99, 100%. So all these patients who started, they take the medication for 12 weeks and they're cured of hepatitis C. Mavyret, which was approved in 2017, it's 3 pills daily. It's also pan-genotypic. It's basically 8 weeks for all naive patients, including with compensated cirrhosis. But you could use it in experienced patients, and depending on if they have resistance or cirrhosis, it could be for 12 or 16 weeks. There's no issue with patients who have kidney disorders. Epclusa, if they have renal insufficiency, you might want to avoid it, whereas for Mavyret, you can even give them even if they're on dialysis. But you can administer boosted protease inhibitors as far as HIV is concerned, or atorvastatin. So I've had patients who I've started on Mavyret, but I've switched them from atorvastatin to another statin like rosuvastatin. And for experienced patients, again, for the 8 to 16 weeks, it sort of depends on whether or not they've taken in the past, and whether or not they have cirrhosis or not. And then another medication we use is known as Vosevi. I apologize for not saying out the generic name because it's a lot of letters. Anyways, basically it's 12 weeks of therapy for those who may have failed one of the prior regimens. And then there's excellent efficacy with people with prior failures. With monitoring, we used to monitor like every 4 weeks, but there's no longer a need for that, especially with the excellent medications we have. And then follow up with, you check the CMP because you want to make sure about the liver and kidney function, as well as hepatitis C viral load at the end of treatment, as well as 12 weeks after completion. So at the end of treatment, you want to document that they are undetectable after finishing treatment. And then documenting for a cure is having them come back 3 months later and checking the viral load one more time for documenting SVR12. So sustained virological response at 12 weeks. And if they are negative, then you have a patient who is cured. So Hep C treatment, IV drug use. So coming back to our patients, depending on where the study is done, there's about 10 to 70% seroprevalence of Hep C in IV drug users. They should be offered drug treatment as well as Hep C treatment. Drug use is not a contraindication. Now, when I started taking care of Hep C patients here in DC, they sort of wanted patients to be clean before starting, especially because the medications, at least at the outset, were very expensive. When Harvoni came out initially several years ago, it was $84,000 for a 12-week treatment, basically $1,000 per day. And the payers really restricted it to patients who needed it the most. So if you had a low Fibrosure score, if you didn't have much fibrosis, then they wouldn't give it to you. You'll be declined because they wanted to save it for patients who had more fibrosis. And obviously that was very frustrating for patients who knew they had hepatitis C, but weren't able to get cured for it. But those guidance or that restriction on the patients with more fibrosis was lifted about a year or two ago, especially in DC Medicaid. So now essentially almost every patient will get approved for hepatitis C treatment, including if they have a positive drug test. But that is part of the, when you send the labs to get the prior authorization, one of the things they're looking for is a drug test result. It's important for linkage to care. So regardless of drug use, there's still up to a 95% cure rate patients who are utilizing drugs and treating for hepatitis C. Continue and consider annual testing of Hep C RNA after cure of patients still engaging in risky behaviors, and continue harm reduction services as well. And this goes over pretty much all of what I just said. The active or recent drug use is not a concern for reinfection, is not a contraindication for Hep C treatment. Here's just one study showing either treating patients with Epclusa who are injecting drugs. And this is considering either directly observed therapy, so they're coming in every day to get their pill, as opposed to unobserved hepatitis C treatment. And if you just look over here on the right, the SVR12 for all these patients, and I think it's over 100 patients in the study, was about 90%, regardless of whether or not they were observed or they did not have the directly observed therapy. And then lastly, I just want to go over the DC Medicaid form. So Medicaid in DC still has you fill out a form. The patient to sign a form, actually MedStar did not have this when I just had my recent patient, but I think the other MCOs do. And basically going over the fact that they understand the risks and benefits of taking Hep C medication. They understand that if I'm not committed to this regimen, I put myself in jeopardy with treatment failure and denial of medication coverage. I understand that only one course of therapy is allowed in his or her DC Medicaid lifetime. Again, this is when it was very expensive. It's still expensive. Epclusa now is available in generic, but it is still, I think for either of those treatments, I still think the cost is still about like $15,000 as the wholesale price. So initially, DC Health is like, listen, you're using drugs and you screw it up, then we're not going to give you another therapy. You're done. In practice, I didn't necessarily see that. I did see DC government redoing that. And again, I think a lot of these concerns are lifted at the time, but these were the forms we had patients fill out. And I think for some of the MCOs, we still have them fill out to go over that. So our patient was taking a buprenorphine naloxone. He wasn't completely sober. He was using drugs like maybe once a month, but he was certainly using less drugs than before. And actually that's a very important part of MAT, is because we are doing harm reduction. And certainly they're less likely to overdose if they're using heroin once or twice a month as opposed to every day. And then he just was started on the Epclusa daily. So we'll see how he does. But again, we are confident that assuming he takes it every day, which he should be able to, that he will be able to be cured of hepatitis C. And so these are some of the sources. Again, Hepatitis C Online through the University of Washington is an excellent resource, especially about individual medications, as well as HCVguidelines.org through the IDSA and the AASLD. I didn't go over drug interactions here, but hepdruginteractions.org through the University of Liverpool is also excellent if you're concerned about starting a medication and whether or not it is interacting with anything they might be on. And then that study I cited earlier is from PLOS One. And that is it. So it is 12:55. Are there any questions? So I hope, again, I think it's just important that obviously it's very important to start medication-assisted therapy as a form of harm reduction and in treatment for those patients. But I think it's also important to sort of consider Hep C treatment. Hep C treatment, when I started out as an infectious disease fellow, the cure rates were like 20 or 30%. People were getting injections every week of interferon. They were getting anemia, depression, fevers. It was horrible, and it wasn't that successful, especially with patients who were either African-American or co-infected. But we're very fortunate now that that is no longer the case, and the treatments are excellent. And again, they take 3 pills a day for 2 months, or 2 pills a day, or 1 pill a day for 3 months and be cured. So looking at the Q&A here. Thank you. That was great. Will the slides be available for you? I think Henry should be able to answer it, but I believe this is being recorded, and I think you'd be able to read that, right?
Yeah, I think we can. I'll be sending out an email with a link to get CME credits, and if you're not in the position to receive CME credits, I'll also have a link just for you to take a survey, and in that email, I can have the slides and recording ready for you all. That should be in between 24 hours and 48 hours from now. And then
there is a question, I'm sorry, from Ms. Bacon, Melanie Bacon, if when is buprenorphine discontinued? So that's really something that we work on with the patients. You know, you know, I've been able to taper a few patients off, but really if they're taking 30 films or 60 films or 90 films per day, you have to sort of slowly taper them off. And it's really sort of guided by the patient, because the patient is the one who's ultimately going to determine whether or not they're in withdrawal or whether or not they're having urges or things like that. So sometimes it takes a while. And oftentimes, especially if I have patients who are sober and drug-free for 6 months or a year or 2 years, I'm really encouraging them to cut back. You know, instead of taking 3 films a day, take 2.5 and see how you do. And then you still have the extra half film. So if they do that and they come back to me and they're like, well, you know, I only took 80 films this month instead of 90. Okay, let me prescribe you 80 this month, and then maybe 70 the next month or in 2 months or things like that. And a lot of times the tapering really is sort of dependent on what's going on in the patient's life. If they, you know, if they have other things going on, if they have obviously other life stressors related to work or employment or sick family members or homelessness, or you know, their depression being exacerbated, things like that, they may not be in the right place to try to get them off. But obviously that's the ultimate goal. But yeah, Q&A, I guess no other questions there, and in the chat. Great.
Awesome. So thank you, Dr. Serlin, for that presentation. That was very informative and I'm sure super helpful. So I know we're at time, but if anyone would like to, since this is a webinar and not a meeting, it's kind of difficult, I guess, to engage in a dialogue. But if anyone would like to speak on any resources or any approaches to getting patients into MAT treatment, if anyone wants to speak on that, I think you're allowed to raise your hand, and then we can add you as a panelist or allow you to talk. So I know, again, this is supposed to you know, be a COP and have dialogue. I think the next meeting we'll make it a meeting so that we can all just kind of join in. So apologies for that. But yes, if anyone has any anything they'd like to share before we log off, you're more than welcome to just raise your hand.
There was a question from John Desmarteau. Is there a difference in the sensitivity of fentanyl test strips or carfentanil? I actually am not as familiar with that. I don't know if one of my colleagues from FMCS who actually give out the test strips, that they have a little bit better understanding, but I don't know the answer to that.
Cool. So we'll give it just one more minute if anyone wants to mention anything. And if not, no worries. But yeah. I'm seeing none. So I think we're probably all good on that then. And oh, we do have one hand raised. Let's see. Okay. Okay. Cool. So Mehran, I'm not sure if I pronounced your name right, but if you do, just want to unmute yourself and comment.
Oh, he said it was by error. There was a question about, do you advise giving out naloxone to every patient that picks up oxycodone? I think certainly there certainly are guidelines that suggest that if you have any patients who are taking any opioid therapy, whether it's, you know, buprenorphine or something related to you know, pain control or whatnot, I think certainly there are guidelines that suggest that they should probably get a naloxone prescription as well.
Awesome. Wonderful. Well, since we're at time, I think we can probably wrap it up. And we'll be having another COP in the future, probably around next month at some point. So, and we'll make sure that that it will be a meeting instead of a Zoom webinar so that everyone can join into. But yes, Dr. Sterlin, thank you so much. This was such a great presentation. I learned a lot myself, and I'm sure everyone else did. So thank you so much.
And again, I think,
thank you.
you know, we do have a lot of resources at Family Medical Counseling. So, you know, certainly if you guys in the community have patients who may benefit from buprenorphine therapy or substance abuse therapy, or things like that, please feel free to refer them over to us. Thank you very much.
Thank you. Thank you so much. Thanks everyone for joining.
Bye-bye.